We move to the next speaker. So the next speaker is Dr. Mauro Mazzucco and Alessandro Vario. The talk will be concerning microwave ablation, microwave thyroid ablation. So please.
Dear colleague, dear chairman, first of all, my personal thank you to Dr. Mazzucco for this opportunity, and thank you, obviously, to Professor Valcavi for the invitation. So, let's start immediately with this clinical case. 65 years old woman. She suffers since about 1 month from thyroid swelling and difficulty in swallowing. Only history of high blood pressure, no thyroid problem in the past, and no familiarity in the gentry. From the physical point of view, only a soft, unpainful swelling of the left lobe of the thyroid. The patient made a cervical resonance a few years ago for other reasons, and these exams showed the presence of this cyst that was not further be investigated. Normal thyroid function, negative the autoantibodies. As you can see, the ultrasound showed the presence of a voluminous mixed anechogenic formation with hyperechoic spots of about 4.5 centimeter in the left lobe of the thyroid, with normal vascular pattern and not suspected lymphoadenomegaly. Obviously, we proceeded to an aspiration of 27 cc of brown liquid, and the next cytological examination shows the presence of a colloidocystic goiter in hemorrhagic regression, the classical tier 2. 10 days after this procedure, the patient still complains of swelling and a sense of bulkiness. So, what will you do now? Let's review together the main Italian and American guidelines for P. Obviously, we in Veneto use a different kind of alcohol, but I think that the result is the same. So, P is safe and effective. It performs a careful sampling of the solid component of the lesion, and it is the first-line therapy for recurrent thyroid cysts, while it is not recommended for solid nodules, even if they are hyperfunctioning or not, and for multinodular goiters. P can be considered for hot nodules, but only when the other modalities are not accessible. So, do we all agree on P in these patients? Now, just a little history about the injection of chemicals into thyroid cyst nodules. As you can see, there is also a work of Dr. Valcavi. Outcomes are absolutely encouraging because the majority of the patients have a significant and lasting reduction in the volume of the lesion. This approach is therefore endorsed for recurrent cysts after simple aspiration. However, there are not studies that directly compare this technique with surgery, so in the many of the study groups, the clinical indication is unclear. Those issues notwithstanding, we clinicians should consider such approaches in selected patients. Getting a little more into the numbers, according to this study, ethanol injection is ineffective in about 20-25 of the patients, with evidence also of a high number of sessions, about 3, and injection of still amounts of alcohol, small amounts of alcohol. Also in this other study, about 20% of the patients had a relapse after ethanol injection, half early, half late. All these 41 patients then were treated effectively with radiofrequency. The multivariate analysis show that the factor independently related to the volume reduction is initial volume and vascularity. Finally, another 33% of failure after ethanol injection in this study. And again, all these patients were treated effectively with radiofrequency. This is a study that directly compares radiofrequency versus ethanol injection. As you can see, there wasn't statistical significant differences between the two techniques. Even thought radiofrequency was effective in all the patients. And also, still the few patients, only 2, who failed ethanol injection, then we all respond to radiofrequency. The radiofrequency, in any case, provides for a smaller number of sessions and is preferred by the patients. It's important to note that costs are, as a note, completely different. So, up to now, we spoke about chemical treatment. But what about the physical treatment? Laser was presented before my presentation. And the other 2 who speak this day is radiofrequency and microwaves. The first point I want to underline immediately is this. The temperatures that we recorded during radiofrequency and microwaves ablation illustrate the faster heating and the faster heating here and the higher temperatures that we achieve with microwave without any plateau. There is a plateau with radiofrequency, and with propagation and with the progression of heat storage. So, few concepts, but I hope very clear, between the difference, about the difference between radiofrequency and microwave. So, radiofrequency acts by ion agitation. Microwaves act by the rotation of the dipole water. That happens several billion times per second, with consequent friction and heat development. With microwave, there is absolutely no influence on the type of tissue. So there is no limitation due to height impedance. The height impedance limits the radiofrequency that do not propagate in tissue without impedance. And there is no influence by the carbonization. Thanks to the microwave, we can obtain higher temperatures with greater speed, and therefore, the so-called heat sink effect, so the capability of the vessel to take away the heat after the procedure, is less with microwaves. Finally, with microwaves, there are no plates, so we can use this technique also in patients with pacemaker, prosthesis, or other devices. Moreover, the major limit factor for microwaves is the diameter of the antenna. The diameter of the antenna is about 14 or 16, while that of radiofrequency is 18. As you can see, the radiofrequency electrode is cooled, and it produces an ellipsoid-shaped ablation zone. And thanks to the less heating along the shaft, it results in less damage of the patient structures like skin or muscles. On the other hand, the microwaves antenna are usually uncooled, so it induces a teardrop ablation zone, the so-called comet effect, as a result of additional heating effects along the shaft. So, eventually, side effects are possible for the structures near the thyroid. This is a study that directly compares microwaves and radiofrequency. Immediately, the conclusion is this. Both systems are suitable to treat thyroid nodules, and there are absolutely no differences in the duration of application, energy transmission, and volume reduction. But, however, microwaves require less insertion to treat the whole nodule, and therefore there is a lower risk of needle displacement inside the nodule during treatment. The same concept was also discussed in this Italian study, in which the effectiveness of microwaves is unquestionable, but the problem of the diameter seems to be the major limiting factor in the use of this technique. Also in this study, the efficiency of microwaves and radiofrequency are comparable, but the authors in this study report less pain occurring during treating without microwaves, but without any explanation. In this study, compared to radiofrequency and local alcohol injection, the microwaves has the following advantages. produce higher energy, so a larger zone of ablation. It is necessary shorter treatment time, and we can obtain the completeness of tumor inactivation, particularly in the treatment of the thyroid nodules with larger volumes. Note that there is a reduction in the volume of the lesion from the average of 40 centimeters to an average of to an half at the end of the treatment. The same study clearly describes the remarkable volume reduction of the treated nodules. This is only an example, because in the last 1-2 years there are a lot of studies that consider this kind of treatment also in the malignancy. This issue will be discussed tomorrow, but for our discussion it's important that 2 points. First of all, that we can consider also microwaves to treat this kind of problem, but also that in any case the physical treatment is far superior than that chemical with alcohol. So, first of all, this clinical case of radiofrequency that help us in the comparison between the microwaves. This is the radiofrequency electrode, and this is the needle that we use for emptying the chest. Now we are emptying the chest, and at this moment the action of the radiofrequency begins. Now, as you can see here, a clot is formed on the tip of the needle, and this prevents the propagation of the heat. So the generator suspends the supply of energy for the development of high impedance. This is why we try to remove the clot unsuccessfully without leaving the thyroid. And this is a type of difficulty that we can find with radiofrequency. In any case, the result was really good. Note that the time needed was 18 minutes, and we use 6 shots. But what about our patient? If there were a cooled device of the same caliber of the radiofrequency electrode, would you choose microwaves? Fortunately, now we have this kind of device. So our answer is yes. So the patient was enrolled for local regional treatment, and considering the characteristic of the nodule, the presence of blood material, the intrachystic cloth, and the wall thickness, we choose the thermal ablation with microwaves. This table describes the type of necrosis we can obtain using different watts and times, and these are the ones we choose considering the size and the type of the cystic nodules. The needle is inside the chest. 3 important points with microwaves. First of all, in many of the cases, in quite all the cases, no emptying of the chest was necessary. Second, the speed of propagation is immediate, and moreover, the propagation continues even in the presence of the clot. Now we moved the antenna towards the wall, also to hit all the wall. Note that the time needed was about 11 minutes, and we used only 3 shots. This is the result obtained at the end of the procedure after 1 month, and this is the patient. This is another example. Quickly, after 3 unsatisfactory sessions of alcohol therapy, we made a radiofrequency with, we consider, really good result. Quickly, these are other 2 examples of cysts treated with microwave with excellent result. And these are 2 more, always fully effective. Note that this cyst was mixed. These are our 12 typical patients with cystic thyroid lesions. In all of them, we achieve a stable and progressive reduction in the size of the lesion. One important point is the cost. As you know, in Italy, or at least in our region, the aspiration of cysts provide for a reimbursement of 65 euros, while the treatment around 2,800. What about the cost? The cost of radiofrequency is 850 for our country. The cost of microwaves is 1,200. And finally, a provocation. As you can see, this is a toxic nodule. The toxic nodule, you can see the scintigraphy, and you can see these images, that is an MFI Philips software that highlights vessels with very slow flow, and this is ultrasonography. In this kind of patient, we perform microwave, 3 shots for 9 minutes. And this is the result. We used, in this case, the lower sensitivity to the heat sink effect that I told before. As you can see, after the treatment, we have normal vascularization, and after 1 year and a half, normal scintigraphy. So, these are our take-home messages. Microwave thermal ablation in thyroid nodules is safe and effective. Up to now, the caliber of the antenna has been a limit, but thanks to the new devices, this will seem to be solved. Compared to radiofrequency, microwaves requires fewer shots and less treatment time. But attention, because microwaves propagate without interruption and at very high temperature, so the risk of complication due to overtreatment may be higher. Microwaves is very effective in cystic nodules or in high liquid component nodules. And finally, our provocation, if this kind of treatment were suitable also for the hot nodules. And last but not least, our thank for your support and patience. Thank you very much.
If you don't mind, just a curiosity. So you show us in the first example how you treat the cyst nodule with the radiofrequency ablation. I'm very curious to know which kind of device, because as you know, nowadays we have the possibility to have a particular kind of needle with the internal and external perfusion, and so you can prevent the problem to have the coagulation around the needle. And so
there are all with internal perfusion.
Yeah,
we
but
use only this
can
one.
you say me the market, the kind of needle?
Mamma mia.
Okay, but we discuss outside. Okay, for this. So.
HS.
Many compliments for your presentation. Short question, which is the anesthesia, local?
Yes. No. Yes, sedation.
Sedation.
We have the anesthetist inside the room, in the operator room.
Okay.
Yes.
Okay, thank you.
Paolo Limone, Torino. 2 short questions. First, have you analyzed if this procedure, as all thermal ablation, are cost-effective for treating the thyroid cyst and compared to PEI, for example? And the second question is, in your series, the solid nodules were very small, 2-3 milliliters. If I only cyst nodules were large, about 14 milliliters.
Yes.
But solid nodules were 2 and 3 milliliters. If I look,
No, but there are the studies.
Yes, in your series.
Yes. In that study.
Do they were symptomatic? 2-3 milliliters were very small nodules.
I think so.